Traditional physical therapy relies heavily on an episodic care model. A patient comes into the clinic, receives hands-on treatment, and leaves with a set of instructions. The primary point of failure in this structure is the time between appointments. This unmonitored gap is the exact window where patients lose momentum, abandon their routines, and regress. Clinical outcomes depend heavily on what the patient does at home. If they do not adhere to their prescribed home exercise program, or HEP, their progress stalls. Yet, without a reliable mechanism to verify compliance, providers are operating blind. We are left guessing whether a patient's lack of progress is due to an ineffective treatment plan or simply a failure to do the exercises. Closing this efficacy gap requires clinics to transition away from isolated treatment episodes and build a continuous care model. The Centers for Medicare and Medicaid Services created a framework to support this transition. Remote Therapeutic Monitoring, or RTM, incentivizes clinical teams to track and manage patients between their scheduled visits. The core regulatory requirement of RTM is the tracking of non-physiological data. This separates it from remote patient monitoring, which looks at vitals like blood pressure or heart rate. Instead, RTM tracks behavioral and subjective metrics. We are monitoring treatment adherence, whether the exercises were actually completed, as well as the patient's self-reported comfort and pain levels on a day-to-day basis. CMS rules state that patients must use an FDA-approved medical device to collect and transmit this information, and a qualified medical provider must monitor their engagement with it. By meeting these criteria, clinics can turn the empty space between visits into a structured, data-driven, and billable period of care. RTM is operationalized through a specific matrix of CPT codes introduced in 2022. Understanding this coding structure is how clinics make continuous care financially sustainable. The process starts with CPT code 98975. This covers the initial setup of the RTM device and the time spent educating the patient on how to use it. It is billed once per episode of care. Next are the device and data transmission codes. These operate on a 30-day billing cycle. If a patient transmits data on 16 or more days within that 30-day period, providers bill code 98977. If data is collected on 2 to 15 days, the appropriate code is 98985. Finally, we have the treatment management codes 98979, 98980, and 98981. These compensate providers for the actual clinical time spent reviewing the incoming data and communicating with the patient. These management codes are billed per calendar month, based on strict time thresholds. Code 98980, for example, requires 20 total minutes of management services. Crucially, logging those minutes requires interactive communication. Providers must have at least one live, synchronous interaction with the patient or caregiver during that month. This tiered structure, paying for the setup, the data collection, and the professional management time, provides the revenue necessary to maintain a high-touch plan of care. The financial model works, but the primary objective remains clinical quality. The critical question is whether tracking this data actually leads to faster rehabilitation. A 2025 publication analyzed this exact variable, tracking 1,224 participants to see if RTM could reliably predict functional success at discharge. The researchers took 306 patients enrolled in RTM and compared them against a control group of 918 patients. To isolate the effect of remote monitoring, the control group was carefully matched by age, sex, case type, and intake scores. This chart shows the study's results against a binary functional status benchmark. The control group, receiving standard in-person physical therapy alone, achieved this benchmark 63% of the time. When RTM was layered into the treatment protocol, the success rate climbed to 72%. With a p-value of 0.004, the data confirms this 9% absolute improvement is statistically significant. It was not a random anomaly. Controlling for all other variables, participation in the RTM program was the single most significant predictor of a patient reaching their functional goals. The data justifies the effort. Adding remote monitoring to in-person therapy directly facilitates superior patient-reported outcomes. Implementing this across a clinic presents an immediate operational challenge. A full-time provider cannot actively monitor daily data and field questions from dozens of patients without sacrificing their in-clinic schedule. To solve this, successful RTM programs introduce a specialized role, the Remote Care Navigator, or RCN. The RCN acts as the patient liaison. They are paired with the provider to guide the patient between visits, track their daily progress, and provide rapid responses that keep the patient engaged. To protect clinical integrity, the RCN operates within strict professional guardrails. An RCN does not have the authority to change the medical plan of care, nor can they add or remove exercises from a patient's routine. Their job is surveillance and triage. If a patient reports rising pain levels or drops their engagement streak, the RCN flags the issue and brings it to the treating provider so they can solve it together. Only the qualified physical therapist, occupational therapist, or speech-language pathologist has the authority to interpret that feedback and medically adjust the plan. By delegating the daily liaison mark, the clinic scales its RTM capacity while keeping all clinical decision-making exactly where it belongs. Getting patients to consistently use their tracking devices requires a specific onboarding protocol. It begins at the end of the initial evaluation with a process called the warm handoff. During this step, the treating provider introduces the remote care navigator directly to the patient. The goal is to immediately frame the RCN not as an automated system, but as a trusted, integrated member of the patient's medical team. The provider should explicitly state, "We do something special here. My colleague will check in on you between visits to make sure we're hitting our goals." Before the patient leaves the building, the staff assists them in downloading the required app and activating their tracking profile. To maintain that engagement, providers must reference the RTM data during every follow-up appointment. Showing the patient that their home data is actively reviewed reinforces the value of their effort. The warm handoff ensures that Logi exercises isn't viewed as busy work, but as a professional commitment between the patient and their clinical team. RTM succeeds because it replaces isolation with a continuous feedback loop. Consistent check-ins generate a sense of accountability, which leads to higher adherence to the exercise program. That adherence directly yields faster physical improvement. CMS recognizes this efficiency, expanding the available CPT codes for RTM heading into 2026. The regulatory betterment is actively pushing the industry in this direction. Remote monitoring is rapidly transitioning from a novel billing strategy to the baseline standard of care. By utilizing the right codes, deploying specialized navigators, and executing the warm handoff, clinics can finally bridge the gap between visits and deliver continuous, measurable care.